and thank you, Dr. Sarnicola, for inviting me. So we're going to talk a bit about a very big topic in a short period of time, so I will move relatively quickly, and as a challenge to the translator, good luck. These are my disclosures, which are not relevant to this talk, and it pales by comparisons to Ed. I'm a little jealous. We're going to talk about three basic areas: tumors of the ocular surface epithelium, tumors of neuroectoderm, and lymphoid tumors. First of all, we have to start with a complete examination of the patient, like we do with all ocular disease. But this requires a very thorough slit lamp examination, especially if you have ocular surface tumors in mind, specifically looking at the fornices, superior and inferior fornix, everting the lids, looking at the palpebral conjunctiva very carefully and the lid margins, looking at the carical and semilunar folds, of course the dilated fundus exam, and palpation of local lymph nodules, the cervical and preauricular lymphadenopathy. So some things that often we do in a very cursory fashion when we examine a patient don't really do all this thoroughly. If you see a lesion, then you have to think of these factors because they have a effect on their prognosis. Is it single or multiple, or multifocal rather? And the areas that I've highlighted are the ones with worse prognosis: pigmented versus amelanotic. Where's the location? Limbal, bulbar, palpebral, fornicele, cornea. Is it solid or cystic, flat versus elevated, fixed versus mobile, and are there feeder vessels? So all these things you should pay attention to if you see a lesion. So let's now talk more specifically about tumors of the ocular surface epithelium. It's the most common of all the ocular neoplasms, and the risk factors of these, which we'll go over a few times, are sunlight, being male, age, advanced age, cigarette smoking, light complexion, immunodeficiency, especially AIDS, and a history of squamous cell CA already of the head and neck, and an HPV infection. The ones we'll talk about specifically here are papillomas, conjunctival and corneal intraepithelial neoplasia, or CIN, and squamous cell carcinoma. Conjunctival papillomas can be pedunculated, like you see here on the upper right, or sessile, like you see on the lower right. Most commonly, they're associated with an HPV infection of type 6 or 16, but they can be associated with type 16 and 18, which gives them a higher malignant potential. They're more extensive in people that are immunosuppressed, especially AIDS patients, for example. Treatment of the papilloma is usually just an excisional biopsy with cryotherapy. You want a complete excision, which decreases the chance of recurrence. You leave pieces of the papilloma behind, and you've got a much greater chance of recurrence. You can treat them with cryotherapy alone if they're small enough or if you want to avoid excision. And with alpha interferon, you can give as drops, 1 million units QID till disappearance of the lesion, or as an injection at 10 million units every month for 6 months. Cimetidine has also been a great adjunct or even a primary therapy at 300 milligrams PO/TID for 3 months to cause involution of the papillomas. Next topic is CIN, which is either conjunctival or corneal intraepithelial neoplasia. Now we're getting to potentially more aggressive lesions. It's a dysplastic process, but it does not invade the basement membrane. Therefore, it's a CIN versus a squamous cell carcinoma. The term carcinoma in situ does apply when it is a full thickness dysplastic process that goes from the surface of the epithelium all the way down to the basement membrane. Pathogenesis is sun exposure, light complexion, like you see these poor 3 children are very light complected. They may look a little bit like me if you happen to look closely. Infection with HPV, especially 6, 8, and 11, which produces a more benign lesion, or 16 and 18, which tends to produce the more malignant lesion. Smokers again, immunosuppression, especially AIDS, and mutations of gene P53. The 3 clinical variants of CIN, papilliform, gelatinous, and leukoplakic. Papilliform. There's a corneal appearance as well, which appears as gray, granular, or a translucent sheet that grows over the cornea, like you see here. It's usually has a limbal origin, even though sometimes it's hard to appreciate the true limbal origin of these. They have a fibrinous margin that's enhanced in staining with rose bengal or lissamine green to define the edges of the lesion. What you worry about in the CIN is advancement to squamous cell carcinoma or differentiation from squamous cell carcinoma. And it's hard to differentiate these on just exam alone, but in general, a squamous cell will be a little more fixed and have more volume. It tends to be more raised. It emanates usually from the limbus at 3 or 9 o'clock. You can have leukoplakia, engorged conjunctival feeder vessels, and on histology, this will then penetrate. We talked about full thickness in carcinoma in situ. Squamous cell carcinoma will then penetrate through the epithelial basement membrane into the subepithelial space. Mucoepidermoid variant, which you can then see only on pathology to differentiate, is the most aggressive type and has the greatest chance for local invasion. Treatment of squamous cell is complete surgical excision with corneal epithelial scraping if involved. You want to add cryotherapy to the margins in a freeze-thaw ×2 or ×3. You can also add mitomycin C in a pledget form from 0.02 to 0.04% at the margins of the excision with care not to place it directly on the sclera. Or you can treat this primarily or with subsequent recurrences with mitomycin C drops, usually cycled QID for 2 weeks, off for 2 weeks, on for 2 weeks, off for 2 weeks. 5-FU works as well as alpha interferon 2 beta. It's about an 80 to 100% resolution with time with interferon, even though this may take 6 to 12 months to totally see it. Switch on to the next general area, which is tumors of the neuroectoderm. And the ones we'll talk about here, we've circled and highlighted, the benign lesions being a benign acquired melanosis or a freckle, ocular melanocytosis, nevi, PAM, and melanoma. So first, the most benign lesions. Conjunctival epithelial melanosis is really just a fancy word for a freckle. You can see it near the limbus, especially in childhood. And you get increased incidence of a darker freckle with darker pigmented individuals. Benign racial melanosis is diffuse pigmentation, like you see in the bottom picture, occurs more in darkly pigmented individuals, especially in Middle Ages, and tends to really be circumferential and close to the limbus. These are benign lesions with low malignant potential. Not zero, but low. Ocular melanocytosis is a slate gray pigmentation of the episclera. It's not truly the conjunctiva. It's really the episcleral tissue under the conjunctiva, and it's associated with a nevus of Oda, like you see in the lower picture. This is a facial pigmentary disturbance. It's an ipsilateral-dermal melanocytosis, and the importance of this diagnosis is the incidence of glaucoma is as high as 10%, and it does have a slightly increased risk of uveal, of not conjunctival, but uveal melanoma. Conjunctival nevus, like you see here, something also occurs in childhood and adolescence, tends to be either junctional compound or subepithelial. It's usually flat in the interpalpebral area near the limbus, although there can be a little bit of elevation, and there can be variable pigmentation. Highly pigmented like you see on the top right, barely pigmented on the bottom right. You can have inclusion cysts like you see on the top right on the surface, which tends to make you think it's more of a benign lesion, but you should watch these for potential malignant transformation in the future. PAM, or primary acquired melanosis, is we're now getting into lesions with potential higher worry rates and higher rates of malignant transformation. It's usually unilateral acquired lesion in a light complected patient. It tends to be flat, brown pigmented, starts and usually is benign, but it needs a biopsy to determine if it's something to worry about. And in biopsy, you can see PAM with atypia or PAM without atypia. If there are atypical cells, the malignant transformation rate can be quite high, 36 to 75% on various, depending on the study you read. What you look for is increase in size, nodularity, and vascularization of these lesions, and you look for the location is a sign for potential worry. So if they're on the palpebral conjunctiva, in the fornix, in the plica or caruncle, or in the lid margins, these are more worrisome lesions than just the ones at 3 and 9 o'clock on the limbus. Treatment is biopsy if at all suspicious. You want excisional if possible, even though some of these are too extensive to completely get. If it's benign, you follow these patients every 6 to 12 months. First every 6 months for probably the first year or two, and then every 12 months after that. If there's atypia on the biopsy, which would be intraepithelial melanocytic hyperplasia or atypical melanocytes, then you want to be more aggressive, more excision if possible with topical chemotherapy, which usually is mitomycin C, 0.04% QID for 2 to 4 weeks cycled on and off. Melanoma is the big worry in this category, obviously. Incidence about 1 per 2 million, higher in people of European descent, more rare in blacks and Asians or darkly pigmented patients. Overall mortality can be as high as 25%, especially if there's lymphatic spread to the cervical nodes. So the preauricular and anterior cervical nodes, as we mentioned in the beginning of the lecture, is where you want to look for possible spread of this. Pathogenesis of melanoma is about 70% comes from PAM, 70% from PAM, about 20% from nevi, and about 10% de novo, which is significant because these de novo lesions are the most aggressive. Tends to be more in the bulbar than palpebral conjunctiva. About 25% can be relatively amelanotic. And again, the poor prognosis group are patients with a palpebral, fornicel, or caruncle location, a thickness of greater than 1.8 millimeters, deeper invasion, lymphatic spread, lid margin location, or a pagetoid or interepithelial spread on biopsy, on the histology. Treatment, complete no-touch excision. You don't want to kind of mess up or irritate these cells, so you want to get around them 2 to 4 millimeters on all sides to leave a 2 to 4 millimeter margin, and then cryotherapy to the conjunctival margins. You want to make sure you identify an ocular pathologist to send this to on filter paper. You don't want to mess around with a pathologist that does not have experience in these, so even if you have to send it to another city, it's worth doing to get a proper diagnosis of the amount of involvement. You can repair these once they're excised with conjunctival or amniotic membrane grafts, and you can do adjunct chemotherapy again with topical mitomycin, usually in a cycle of 2 weeks on QID, 2 weeks off, 2 weeks on, 2 weeks off. Metastasis again can be around 25-26%, with death as high as 13% at 5 years. So this is the one we really all are worried about, and in our back of our mind are kind of thinking about it all times when we see a pigmented lesion. It's worse if the origin, again, is de novo versus from PAM, for example, and if they're positive margins, and if it's not at a limbal location. So in summary of the pigmented lesions, you can see on the far right, nevus has very low pigmented potential, ocular melanosis, very low pigmented potential. Melanocytosis can give you a low chance of uveal but not conjunctival melanoma. PAM can give you somewhere in that 36 to 75%, especially if atypia on biopsy. Malignant melanoma can have a mortality rate of 25-26%. So lastly, in the last couple of slides, we'll talk about lymphoid tumors. First thing that you want to differentiate is lymphoid hyperplasia, which is a benign lesion, salmon-colored, kind of pebbly appearance. Usually here you see it inferiorly in the inferior fornix, usually younger patients, 40 years old or younger, and often 20 years old and younger. It can be a B-cell lymphoma, but it often is not. You need to biopsy this tissue and send the tissue fresh. So don't put this in formalin, keep it fresh. In saline, send it to the pathologist to rule out a B-cell lymphoma. What you want to rule out is this more confluent lesion you see along the inferior fornix, which is a conjunctival lymphoma. About 2 to 8% of the extranodal lymphomas that people get in their bodies can show up in the ocular adnexa, and about 30% of these show up in the conjunctiva. Most of the time we see a conjunctival lymphoma, though, it's a primary disease. They can be bilateral in somewhere in 20 to 38%. They're all B-cell lymphomas, usually non-Hodgkin's B-cell lymphomas, and most of them are MALT lymphomas, about 68-81%. Follicular lymphoma in about 8 to 16%, mantle cell in 3 to 7%, and diffuse large cell in 3 to 4%. And the prognosis gets worse as you go down here. So MALT's the least to worry about, down to mantle cell and diffuse large cell lymphomas are more worrisome. And again, about 20% of these primary conjunctival lymphomas that first show up at the conjunctiva can go on to become systemic lymphoma. So you have to rule out systemic involvement. You need an orbital CT or MRI. You need routine blood tests, usually done by your internist or even better by oncology. CBC with differential and immunoelectrophoresis. CT of the chest, pelvis, and potentially a bone marrow biopsy to rule out systemic involvement in these patients. Treatment, again, fresh biopsy to get the lesion so you can stage it. And then usually when you make that diagnosis, it's treated with localized external beam radiation, 30 to 36 gray, usually given over about 20 sessions or so about 1.6, 1.8 per session. And you get about 90% remission with this treatment. Intralesional interferon alpha is also helpful, injected in the lesions, and intralesional rituximab has also been shown to be helpful. Recurrence can be as high as 38% at 24 months, so you need to follow these people closely. Suggested follow-up is about every 6 months. So we've gone through a whirlwind of ocular surface tumors, hopefully enough to educate you and maybe frighten you a little bit so you keep your eyes out for these potentially dangerous lesions. Thank you very much.